Good evening, everyone, and welcome to this webinar on significance of homologous recombination repair testing, genes testing in ovarian and prostate cancer. So without taking much time, I would quickly like to introduce our speakers for this particular webinar. Our first speaker, the first speaker is Dr. Indranil Ghosh. Dr. Indranil Ghosh is one of the leading medical oncologists in Calcutta and also currently is associated with Apollo Hospital as a consultant medical oncologist. He has a 16 plus years of experience and he has done his MD, MBBS from college in Calcutta and MD from All India Institute of Medical Sciences. And Dr. Ghosh was also associated with breast and was in charge of the breast and gynecological cancer chemotherapy unit at Tata Memorial Center, Calcutta. Our second speaker for this webinar is Dr. Arun Kumar, who is an oncogenetic expert at Genome Labs. And Dr. Arun has 15 plus years of experience in human genomics and has a PhD in human population genetics. So I would also like to inform all our viewers that we will be taking up questions at the end of the session. And I would quickly like to call upon Dr. Indranil Ghosh to start his, to talk about homologous recombination repair gene testing in prostate and ovarian cancer. So over to Dr. Indranil.
Thank you and good evening. So today I'll be discussing on the significance of HRR gene testing in various solid tumors. And nowadays it's a very important topic because a lot of predictive and prognostic significance is there for HRR testing. I'll start with the very basics of DNA repair mechanism because homologous recombination repair is a repair mechanism. So where is its place among all the DNA repair mechanisms in the cell? So let's take a single strand break. For that, we have the base excision repair. Here you can see there is a break in a single strand. The other strand is intact. So base excision repair by PARP, XRCC1, ligase 3. These enzymes are involved in this pathway. If there is a double strand break, principally we have two mechanisms, homologous recombination and non-homologous end joining. So in homologous, basically they are taking the other sister chromatid as the template and then repairing the other strand, other chromatid. So in homologous recombination, we have these various proteins like BRCA1, 2, PALP2, ATM, CHEK1, CHEK2, RAD51. And non-homologous end joining, it's by other mechanisms like the KU7080 or DNA PK mechanisms. If there is a bulky adduct, you can see in this DNA, there is a very bulky adduct mostly by usually radiation. For that, we have nucleotide excision repair. So as opposed to base excision, where only the base is taken out, in nucleotide excision, the entire nucleotide is taken out. ERCC1 and 4 are the principal proteins. If there's a mismatch, we know that one strand has to match the base of one strand has to match accordingly with the base of the other strand. But if there's a mismatch, then that is repaired by mismatch repair pathway, MSH2 and MLH1 principally. If there is an alkylation and proof, it can be taken care by proofreading by MGMT pathway. So all these pathways are there. So what is homologous recombination? It repairs DNA double strand breaks, principally in the S and G2 phases of the cell cycle. And it's a conservative process because it restores the original DNA sequence at the site of damage. It's accurate. The first step, the lesion is recognized by the mRNA complex, MRE11, RAD50, NBS1, which in turn activates the ATM kinase. Upon the DNA 5' end resection, the replication protein coats the single strand DNA region and activates the ATR kinase. In the following steps, RPA is replaced by RAD51 with the help of further repair associated proteins like CHEK2, BRCA1, 2, and PALP2. These are loaded with RAD51. Subsequently, the defective DNA strand attaches to its sister chromatid, which is used as a template for DNA resynthesis. So it's restricted to the late S and G2 phase because replication is an important part of this pathway. And if you can remember, homologous recombination is also very important in the meiosis cell division, which is required for the spermatocyte and oocyte production, because it leads to variation or exchange of information between the chromatin and leads to variation in the subsequent offspring because of this pathway. So that is one role of that homologous recombination, and here it's also repairs the DNA back to its original state. So this is the pathway, double strand break, this mRNA complex ATM, then BRCA1, BRCA2, RAD51, leading to homologous recombination repair, which is accurate. As opposed to the other alternatives, non-homologous end joining. So it is not using any other template. It is just joining the two ends of the break. This is inaccurate. Also, there is a single strand annealing, which is also inaccurate. So once this homologous recombination pathway is damaged, then the repair will be taken over by these inaccurate mechanisms, and which will leave a scar in the genome of that tumor or that patient. So this is the genomic scar concept. So like a scar which forms in our skin or any organ because of wound or previous surgery. So in the cell also, in the DNA level, there is a scar is forming because of impairment in homologous recombination pathway. The cells will activate the alternative NHEJ pathway for double strand break repair, which is prone to ending in chromosomal rearrangements, and this resulting genomic instability will be observed as genomic scars. So homologous recombination deficiency is a state where the DNA repair is hampered by homologous recombination pathway, most commonly by the loss of function mutations in cancer like BRCA1, 2, RAD51 or PALB2, or promoter hypermethylation of the BRCA1 gene promoter, which will lead to epigenetic silencing of BRCA1. So how to estimate this homologous recombination deficiency? Three techniques are there. One is a germline mutation screening of all these genes. So it will pick up the mutations in the specific genes, but it will miss some of the somatic genes and also the genomic scar. Second option is to do somatic mutation screening of all these genes. Again, it will lead to both germline and the somatic mutation in these genes, but it will not give us an estimate of how much the net effect on the genomic instability is there, because all genes in all tumors may not have the same effect in the genomic scar. The last one and the most comprehensive is the evaluation of genomic scar, which represents the genomic instability secondary to HRD. Irrespective of the mutations, what is the end result in the genomic instability? So it is calculated based on three parameters: loss of heterozygosity, telomeric allelic imbalance, and large-scale transitions. I will explain them one by one. LOH is loss, or this either by deletion of one allele. So there are two alleles of one locus in one cell. Now, if one of them gets lost, then it becomes copy loss LOH. So the other copy is remaining. The parental copy and maternal copy, they're different. But once one is lost, then that heterozygosity is lost. One copy is remaining, that is either paternal or maternal. Or it can happen by deletion and simultaneous duplication of the remaining allele. So suppose the maternal one is lost, but the paternal one gets duplicated. So the copy number remains same, but still it is loss of heterozygosity because the maternal allele is lost. Second is telomeric allelic imbalance. It is defined as the number of regions with allelic imbalance extending to the subtelomere. Telomere, you know, the end of the chromatin. So this imbalance extends to the subtelomeric region, but it does not cross the centromere. Centromere, you remember, is the center of the chromatin. And large-scale transition is defined as a break point which occurs between adjacent regions of at least 10 megabase. So if a 10 megabase region is lost or inserted in an adjacent, a continuous region of at least 10 megabase, it becomes a large-scale transition. This is one example, one diagram giving all types of examples. First one is the example without any HRD. So here, if you see, there are 6 alleles are represented. On one side paternal, one side maternal, A to F. And each allele is, let's say, 3 megabase length. So here, obviously, all alleles have one paternal component, one paternal allele, one maternal allele. So there is no LOH. There is no insertion or duplication of any segment of DNA. So there is no large-scale transition. And the subtelomeric alleles are intact. So there is no telomeric allelic imbalance. So all 3 are crossed. So this is normal. Let's take this example. Here, B to F are okay. But not okay, sorry. This blue one, let's say it was from the maternal side. So if you see here, as compared to the left example I have shown, this all the most 5 alleles in the blue side are replaced by the orange side. So all of these loci, there is loss of heterozygosity. These are all homozygous from either parent, not from both parents. So loss of heterozygosity. It's also a 15 megabase break. So this entire 5 alleles are replaced by the 5 alleles from the other side. 15 megabase change. So it's a large scale transition is there, but subtelomeric allele is okay. So there is no telomeric allelic imbalance. Let's take this example. Here also, if you see here, a 15 megabase alteration is there. So all the blue alleles are lost except F, and they are replaced by the orange alleles in both sides. So LST is there, LOH is there. In addition, the subtelomeric locus is also altered. So there is telomeric allelic imbalance. So all 3 are tick. In this example, in one side, everything is lost. So it's a copy loss LOH in all the locus, all the loci. 15 megabase is lost. So LST is there. And the subtelomeric is also lost. So TI is also there. Let's take this example. Here, A, B, C, D, E, F on this side is there. Here, A is replaced by the other side. So TI is there. But LOH is not there, as for all loci, we have the paternal side and maternal side. And the alteration here is insertion, or the B has become, from 1 has become 3. So insertion is there, but it is only 6 megabase. So it is not LST. So only TI is there in this example. In the next example, if you see, B instead of 1 has become 5. And it's a 12 megabase alteration. So it's a LST is there and others are not there. In the last example, it's interesting because here also, for all loci, we have blue and orange. But B has become 1 to 3. So 6 megabase alteration is there, which will not qualify for LST. And there is no LOH because for all loci, we have maternal and paternal, and the subtelomeric is okay. So here there is no TI. So like this, we have to do for the entire genome and calculate how much we have to quantify the LST, LOH, and TI, and then find out the total genomic scar. So frequency of pathogenic variations in HRR pathway. So HRD, if you see in the Cancer Genome Atlas in ovarian cancer, it's very common. Almost 50% of women with ovarian cancer will show some form of HRD. Now, some of them will be having BRCA1 germline, some of them BRCA2 germline, some of them somatic BRCA1 or BRCA2, or epigenetic inactivation of BRCA1, or some other mechanism from other genes. But if you take only germline variant of BRCA1 and 2, maybe you will get 15%. If you add somatic, you will get 20 to 25% max. But only when, if you do the HRD genomic score analysis, you will be able to pick up the rest 20-25% of patients. These are the various genes in the HR pathway in epithelial ovarian cancer. BRCA1 and BRCA2 mutation, if there, they confer 44% and 17% lifetime risk for ovarian cancer respectively, in contrast to 1% or less in the general population. In RAD51, prevalence 0.3 to 1.1% with a 6-fold increased risk for ovarian cancer. Heterozygous BRIP1 damaging variants have also ovarian cancer susceptibility. So this, so many mechanisms are there. But remember, as I said in the initial part, PARP is not a part of homologous recombination, but rather in the base excision repair. So why PARP is important for HRD patients? Because of the concept of synthetic lethality. If the homologous recombination is already impaired and the other base excision is we can impair by giving PARP inhibitor, then the number of mutations which will accumulate will be lethal for the cell, and the cell will go to apoptosis pathway. But PARP is directly not related to the HRR pathway. So why to detect these genetic variants? Because appropriate clinical management of cancer patients can be there by targeted therapy. Because we can give them PARP inhibitors, so that can improve their prognosis. Primary prevention of ovarian cancer. So this is important for the family members. Once we detect an index case of harmful pathogenic mutation or likely pathogenic mutation, we have to screen the family, and in those patients, we can be identified through cascade testing, and those who will be carrying those genes can be offered risk-reducing options, which will ultimately lead to reduced morbidity and mortality. And some of the risk-reducing options are like bilateral salpingo-oophorectomy and mastectomy. In breast, still we can do regular screening with MRI, but in ovarian, screening is less effective. So bilateral salpingo-oophorectomy after the completion of family is a good option. So as I discussed, because of the importance of various therapies like PARP inhibitors for ovarian cancer, as also for the family screening. Now for family screening, we obviously need a germline mutation. HRD on the tumor tissue or somatic mutation on tumor tissue is not enough. If we identify those, then we still have to look for the germline mutation in that index case. And if present only, then we are going to test the asymptomatic family members. And as compared to germline, we get additional 4 to 7% mutations through somatic testing. So many tests are there. What is the level of evidence and the clinical utility? Germline BRCA, level of evidence 1, clinical validity is good, clinical utility is there for first-line maintenance. If germline BRCA is there, we can give first-line maintenance PARP inhibitor, as also in platinum-sensitive relapse disease. Tumor BRCA, same. Level of evidence and clinical utility and validity is the same. Somatic BRCA. So by tumor BRCA, we mean both germline and somatic. Once we filter out the somatic only, the level of evidence is a bit weak. Clinical validity is a bit less good versus fair. But yes, utility is there for first line and second line maintenance. We can give PARP inhibitor. Non-BRCA mutation HRR genes like RAD51, PALP2, etc. Level of evidence bit weak, level 2. Clinical validity is marginal. For first line maintenance, no evidence. For relapse disease maintenance, marginal. So this is the weak link. So apart from the family screening part, from treatment point of view, non-BRCA HRR gene testing has got little role. Genomic scar assess, either LOH alone, because LOH is a component of genomic instability score. LOH alone is level of evidence 2, clinical validity good, but for first line maintenance, we cannot use it because there is no data. For second line maintenance, there is, so it's good. GIS score has a level 1 evidence and clinical validity is good. And both for first line and second line, there is data. So again, it's good clinical utility for first line and relapse setting maintenance. So this is the myriad my choice companion diagnostic HRD genomic instability assay. So it takes into consideration number 1 BRCA mutation and number 2 genomic instability. Genomic instability is by the 3 parameters I discussed. So this is from the Paula-1 study, olaparib plus bevacizumab versus placebo plus bevacizumab maintenance in first line. So with tumor BRCA mutation, you can see there is a good difference. Hazard ratio 0.31 for olaparib versus placebo. Patients without tumor BRCA, it's less. Hazard ratio 0.71. But patients with HRD tumor, including the BRCA, here hazard ratio is same as like BRCA, 0.33. And most importantly, patients with HRD tumor without BRCA mutation. So there is non-BRCA HRD, also known as BRCA-ness, like BRCA but not having BRCA. Here also the hazard ratio is 0.43, almost similar to that of tumor BRCA. So this is the validity of the test. If you have high HRD tumor without BRCA, the role of olaparib in first-line maintenance is definitely there. In comparison, the foundation-focused companion diagnostics BRCA LOH. So here they are testing only the loss of heterozygosity. This is from the Ariel 3 trial of rucaparib versus placebo maintenance in relapse setting, platinum sensitive. In the tumor BRCA group, the hazard ratio was 0.23 in favor of rucaparib. In the HRD group, it was 0.32. This is including BRCA, obviously. So almost similar. So here is the validity of that this HRD group, which is basically LOH only, LOH or tumor BRCA, that is validated. But this is for relapse setting maintenance only. This is the synthetic lethality concept. DNA damage happens because of various reasons. Now, this is the base, this is the normal pathway, polyadenosine ribosylation and recruitment of DNA repair enzymes by the PARP pathway leading to DNA repair. And here, if already the homologous recombination repair is impaired, if you give PARP inhibitor, the PARP trapping is there, leading to double strand break accumulation and replication fork collapse, leading to cell death. So various things are there: platinum sensitive, PARP sensitive, HRD. There is overlap between everything. So ovarian cancer patients, we select by HRD biomarker, the HRD phenotype patients, we can predict PARP inhibitor response and stratify them in the primary or relapse setting for PARP inhibitor based treatment. So many trials have shown that. I'm not going into the details, like Solo 1, 2 for olaparib in first line or relapse setting, Nova for recurrent epithelial cancer after previous platinum-based therapy, Prima and Nova are with niraparib. Nova is for relapse setting, Prima for first line setting. Ariel 3 I just discussed, rucaparib in relapse setting, and Paula 1, which is combination bevacizumab olaparib for first line. So germline and tumor testing for ovarian cancer patients should be there for all patients. And one is the somatic testing for the HRD and BRCA for the patient to select her treatment, and then the germline testing for family screening. So all guidelines will recommend at least a germline testing and if possible, HRD testing as well for the advanced stage patients. But germline testing is for all stage patients, irrespective of early stage or advanced stage, because here the importance is screening for the patient herself. Because it's an early stage ovarian cancer and we cure the patient and we miss a BRCA, patient can have a breast cancer also later on. So that is important for the early stage patients. And for late stage patient, we can start with the HRD testing, and if it's positive, then we can go for a germline testing to look for the family screening. Coming to prostate cancer, in MCRPC, people have shown that up to 23% of the patients have DNA repair pathway aberrations in the tissue, and 8% have germline changes. Some studies have showed that somatic and germline BRCA is found in 12%, which almost 90% exhibiting biallelic loss. Another study showed that 11% with metastatic prostate cancer have germline mutations in DNA repair genes like BRCA2, ATM, CHEK2, BRCA1. BRCA2 is the majority in prostate, as you all know. The rest are very few. The profound trial was done based on this in MCRPC, whose disease had progressed during treatment with enzalutamide or abiraterone. Chemotherapy was not mandatory. They were randomized, and these patients were selected by HRR pathway aberrations. Only those patients were taken, and they were treated by either another NHA, like either abiraterone or enzalutamide, but not the previous treatment, versus olaparib. And the PFS was much better in the olaparib arm, and the survival benefit was also there. Rucaparib has also been tested, but it was only a phase 2 study. It has also shown in a similar patient population good overall response rates. So based on this, olaparib was FDA approved for HRR gene variant CRPC. Now in prostate cancer, the testing is HRR gene. In contrast to ovarian cancer, where HRD is important, but in prostate cancer, all the testings were, all the trials were done with HRR gene panel. So this is the thing we are supposed to do for prostate cancer patients. The NCCN guideline recommends routine testing of all CRPC for HRR variation. Not only CRPC, they recommend for all locally advanced and metastatic prostate cancer. And basically any aggressive form of prostate cancer, because mostly the BRCA related prostate cancers are very aggressive. So we need to test them because family screening implications are there. In pancreatic cancer, it's a bit controversial. Not that all the mutations are definitely there. 20% of them have one or more somatic or germline mutations, the genes which I already discussed. And the POLO trial, where olaparib compared to maintenance therapy following platinum-based chemotherapy, had shown a PFS improvement. But it's controversial because in pancreas, our protocol is to continue chemotherapy platinum-based. If we have started with platinum-based like FOLFIRINOX or Gemcis, then we continue it as long as the patient is tolerating rather than stopping. And this was olaparib versus placebo. So placebo arm is definitely a weak arm. So this is controversial, but definitely it's emerging. So NCCN recommend HRR testing for pancreatic cancer, germline testing in any patient with diagnosed pancreatic cancer with comprehensive hereditary cancer gene panel because of, again, family screening implications. Tumor testing is recommended for any patient with locally advanced or metastatic setting to identify potential target, which includes mutations in the HRR pathway like BRCA and PALP2, but also other fusions and MMR pathway for other treatment options. So basically, you have to do a comprehensive genomic profiling. In breast cancer, in triple negative, we all know BRCA1 and BRCA2 are enriched. Few trials like Olympiad and NBRCA have shown that in HER2 negative BRCA mutant, germline BRCA only, no somatic testing here. HER2 mutant, germline BRCA mutant patients, HER2 negative, role of olaparib and talazoparib is there. So triple negative is not the criteria, it has to be HER2 negative and BRCA positive. So testing is recommended, especially in this group of patients, HER2 negative patients who are metastatic. We need to test them. But apart from that, germline BRCA1-2 testing is recommended by NCCN for most patients with breast cancer. Basically, any patient less than 45 or any TNBC less than 60. And other patients who are not fitting into this criteria also, because of they can also be tested if they are fitting the family history criteria. So I think that's all from my side. Thank you very much for patient hearing. I'm sure the next talk will be much more informative regarding the testing scenario and how to test and the methods of testing.
Thank you, Dr. Ghosh. It was indeed a very interesting presentation where we learned a lot about various trials and application of HRR and HRT testing in prostate cancer and other cancers like ovarian and pancreatic. Thank you very much. So next I will start a presentation where I will talk a bit more about the molecular and laboratory aspects of testing, where I will try to demystify the difference between germline and somatic testing of BRCA and the HRR genes. Particularly, I will touch upon where to position and how to position both germline and somatic testing in the diagnostic algorithm, particularly in prostate cancers. So the agenda for my talk today is, we'll start with the basics of sequencing technology, and we'll compare and contrast germline and somatic testing, talk about a bit of variant classification, and I will highlight a small study that we did, a very brief comparative study of germline and somatic testing. So there are two major sequencing technologies. One is the Sanger sequencing, the other is the next generation sequencing. The Sanger sequencing is the gold standard method of DNA sequencing, where you can sequence at a time around 500 to 1000 bases of a sample. It's highly accurate, but it has a very long turnaround time, and the manpower required or the laboratory time required to do this is high. In contrast to this, the next generation sequencing is a very big advancements in the sequencing technology, where you can sequence thousands of bases, even the whole genome at a given point of time in multiple samples. And although the accuracy is a bit lesser than Sanger, but with the advancements in bioinformatic algorithms, the accuracy has improved thoroughly. So to put things in perspective, in Sanger sequencing, you sequence 500 or 1000 base at a given point of time for one individual, whereas in a next generation sequencing, you will be sequencing even the entire genome if required for multiple individuals at the same point of time. So what exactly is this NGS technology? NGS is essentially technology where in the process goes on as follows. You have any sample, blood or tissue or bone marrow aspirate, any sample for the particular disease is taken, and the nucleic acid is extracted out of it, and the DNA is cut into pieces, say 150 base fragment pieces. It is cut, and then we do what is called as a capture, where we use RNA baits to capture the specific genes of interest. So we're not going to do a whole genome. Our objective, suppose, is just to sequence the 15 HRR genes. We design these probes which are complementary to the genes of interest, wash away the rest of the genome, and pull down only those DNA fragments which are of the target that we are looking for. Then we ligate primers on either sides. This process is called library preparation, and we take it up for DNA sequencing. Now, there are very many chemistries of DNA sequencing. The most commonly used one is the sequence by synthesis chemistry used in Illumina sequencing. Then comes the most challenging part of a next generation sequencing, which is the data analytics, where we get gigabytes of data for every sample that we sequence. Now there are a long process of data analytics, and we identify variants in the gene, and we try to make clinical sense out of those variants. So overall, any sample that we sequence, for example, we generate thousands and thousands of genetic variants. Now there are mechanisms by which you filter out the variants, remove out the benign variants, and you try to filter out only the clinically relevant variants. Any variant can be classified into two, as a germline variant or a somatic variant. Germline variant is which is inherited from the parents. It runs in the family. It is there in all the cells of the body. Whereas a somatic variant is restricted to the tissue where the particular cancer is there, or where the particular phenotype is there. Somatic variants are acquired over a person's lifetime. Now, a somatic variant can be a driver mutation. For example, a BRCA1 or a BRCA2 mutation in a ovarian cancer or a prostate cancer are all driver mutations. They actually drive the cancer. There could also be bystander mutations, which are the mutations that accumulate over a period of time as the cancer progresses. Be it a germline or a somatic variant, the variant can be benign variant. Essentially, these are the variants that are there in very high frequencies in healthy population. Or a variant can be a pathogenic variant, where the variant is known to cause the particular disease or the phenotype. There is a third category of variants called as a variant of unknown significance, where we currently the existing literature evidences do not confirm the pathogenicity of the variant. So a variant of unknown significance, which is today, can become a pathogenic variant tomorrow, or can also become a benign variant tomorrow, depending on how the research outputs come out in the scientific field. Now, currently, the guidelines state that you should not make any major clinical decisions based on a variant of unknown significance. So we follow the AMP guidelines for the variant classification, which are somatic in nature, and the ACMG guidelines for the germline variant classification. This AMP guidelines classifies any variant, a somatic variant, into 4 tiers. Tier 1 is a variant of very strong clinical significance, where there is extremely well-made studies establishing the pathogenesis of the variant, and you also have the have therapeutic targets for the particular gene. Classical example, in case of ovarian or a prostate cancer, a BRCA1 or a HRR gene pathogenic variant come under the tier 1 variant. Because they are pathogenic, they are also targetable. A tier 2 variant is a variant which does not have a therapeutic target, but is also implicated in, if not in this particular tumor type, in other tumor types. For example, you identify, a EGFR variant in ovarian cancer. EGFR gene is known to cause oncogenesis, or it's a driver mutation in non-small cell lung cancer. But it is, if at all you find that in a different cancer type, it becomes a tier 2 variant. Tier 3 is the variant of unknown significance, and tier 4 is the benign variants, which I just explained in the previous slides. So 2 PARP inhibitor therapies are approved for prostate cancer, and the guidelines also recommends the genetic testing that is to be done to apply this therapy. So one is the olaparib drug, for which on 19th May 2020, FDA approved germline or somatic HRR mutation to be positive, where a person can benefit from olaparib therapy. Now, it is at a metastatic setting, in the cancer, in the prostate cancer. The other drug is the rucaparib, where on 15th May 2020, germline or somatic BRCA was implicated. So any patient with a germline or somatic BRCA mutation can benefit from a pathogenic variant in that, can benefit from rucaparib. And recently, in the last year, August 2020, the FDA also approved a liquid biopsy based BRCA testing, which is a cell-free DNA testing. If somebody is having a cell-free DNA testing positivity for BRCA, somebody with a prostate cancer being positive for BRCA, they can be given the rucaparib therapy, and this is also at a metastatic setting. So So given the two flavors of BRCA testing also implicates for the HRR testing, there are two ones. One is the germline and the somatic. The rationale of testing this is, of course, germline BRCA testing gives you a hereditary risk assessment. Disease prognostication can be done, and it really improves early detection if identified. Somatic BRCA testing helps you to identify not only the germline variant, but also identify the group of patients who are germline BRCA negative, but somatic BRCA positive. And somatic BRCA testing also helps you identify loss of heterozygosity. And it can be used as first-line testing for BRCA because when you do a somatic testing, you pick up both germline as well as somatic mutations. Why? As I told in the earlier slides, it is any person who is having this BRCA mutation, be it germline or somatic, will respond well to PARP inhibitor therapy. And it is recommended by almost all major guidelines. And at a laboratory point of view, the somatic germline BRCA is done at a sequencing depth of 100x, and point mutations and small insertion deletions are reported. And somatic BRCA is done at a sequencing depth of more than 250x, so that even very low level mutation allele burden can be picked up. And 100% coding regions will be covered. And most importantly, we also report the mutation load. What is the percentage of the cells in the tissue that has the mutation will also be reported in the somatic BRCA testing. So the sample type and the type of germline or somatic flavor of testing needs to be understood. So as I said earlier, the germline mutation is there in all the cells of the body. A somatic mutation is there in the particular tumor cell. Now, there are two types of samples. One could be a blood sample, the other is a tissue sample. A germline variant will be present both in the blood, because it's there in any cell of the body, it is also present in the tissue. Tissue in the sense, the cancer tissue. A somatic variant will be absent in the blood, but will be present in the tissue. So if you do a somatic testing in the tissue block of an individual, you end up identifying both germline variant as well as a somatic variant. Whereas if you do a germline testing, you identify a germline variant in the blood, but not the somatic variant, which could be there in the tissue. So this is the idea of doing a germline and somatic testing. So what is the strategy? One of the major thing which we need to have in mind is that the next generation sequencing will pick up single nucleotide variants and small indels, which account for almost 98% of all BRCA variants. Whereas there is a lowered sensitivity of NGS-based technology to detect large deletions and duplications in the gene. So large in the sense more than thousands of bases where a whole exon is deleted or duplicated. Such kind of genetic variants can be detected by a technology called MLPA, or multiple ligation probe amplification. So for germline BRCA testing, we first need to do a NGS to screen for point mutations. If that is negative, you have to do a reflex MLPA to rule out if there are any large deletions and duplications. The sample type for the testing, for any germline testing, it's 3 to 4 ml peripheral blood in EDTA tubes. And for somatic testing, it is FFPE block with more than 10% tumor content. Now, coming to the second part of the story is the homologous recombination repair gene testing. Now, as Dr. Ghosh had already mentioned in detail about the homologous recombination repair pathway and where it fits in the DNA repair pathway, there are 15 important genes and their corresponding proteins that take part in the homologous recombination repair pathway of the cell. The BRCA1 and BRCA2 are also part of the HRR genes. Now, to see the diagnostic yield and to see the efficacy or the compare between germline and somatic HRR testing, we did a very small study where we took 9 paired samples of blood and tissue from the same patient. And we did both blood-based germline HRR testing and tissue-based somatic HRR testing and did a brief comparison. So what did we find out? Of the 9 samples, we had both a mixture of prostate as well as ovarian cancer cases. And 2 samples, sample 8 and sample 9, had a very poor tumor content in the block, so a somatic testing could not be performed. which is a very common occurrence. Almost in 10% of the cases, you have certain issues with the block preparation that leads to failure of the block, which cannot be taken up for NGS based assays. 2 prostate cancer cases did not have any mutations, both in the block as well as in the blood. And 2 prostate cancer cases had a BRCA2 variants, which were seen only in the block and not in the blood. 3 ovarian cancer cases had one BRCA1, other had RAD54L, the other had 2 mutations, a BRCA2 and a BARD1 mutation. Now, the point to be seen here is that this the value that is given inside the bracket is the variant allele fraction, or the fraction at which the mutation was present in the tumor tissue. Now, here you can see the variant or allele fraction of around 48% and 52%. So any variant which is there almost in this frequency of around 50% in the tissue is in all probability a germline variant, which was also identified in the same mutation was identified in the blood sample of the individual. So the take-home message from this small comparative analysis is that if there is a germline mutation in the blood, that is also picked up in the tissue-based testing. Tissue-based testing also picks up somatic mutations which are not germline in nature. So the diagnostic yield of a tissue-based testing is higher compared to a blood or a germline-based testing. So there was a nice study in 2019, and where they proposed an algorithm, because the point to be noted is in many of the, especially in prostate cancer cases, there is a lot of tests not performed or a block failure that takes place. In fact, in the profound trial of prostate cancer, there were failure rate of the blocks were as high as 33%. So having that in mind, because it has to depend on the nature of the tissue as well as in the way in which a block is prepared, etc. Having that in mind, algorithm was proposed. So if there is first you start doing a tissue-based HRR testing for a prostate cancer, and that is essentially a somatic testing. If the test is performed, the test was fine, you had enough tissue and the test was performed, and if that is positive, you start with PARP inhibitor therapy. If the test was negative, you go in for a conventional therapy. Now, if for some reason the test is not performed, you can do a blood-based germline testing. And if that is negative, you go for a conventional therapy. If the germline testing was positive, you go for a PARP inhibitor therapy and also go for familial screening and prevention strategies. Any somatic testing that is positive can also be done for a reflex germline testing to confirm if the mutation that you identified in the tissue is germline in nature or not. So lastly, I will finish this talk with the very critical factors which needs to be practiced while preparing the FFPE tissue block, because the success of any molecular test purely depends on the manner in which the FFPE block is prepared. So because that's the first step. Now, there are certain histological factors like necrosis, mucus pools, poor fixation, burning effects. All of these kind of factors in the block, in the histological factors in the block, can have a negative impact on the amount of DNA and the quality of DNA one extracts from the block. Apart from the histological factors, there are also other factors such as age of the block should ideally be less than 3 years, because as a factor of time, the DNA starts degrading in the block. The DNA gets highly fragmented. Tissue processing factors are also quite important. Most critical tissue processing factor is the formalin that is used. So the formalin that is used for fixing the tissue has to be a 10% neutral buffered formalin. The time lag between the tissue removal at the surgical site and the fixation should be as minimal as possible. The fixation time should be adequate. So for some tissues, you might require a longer time. For certain tissues, you require a lesser time. So depending on the type of the tissue, the fixation time should be adequate. There should be no under fixation, nor there should be over fixation. Contaminants such as acids, heavy metals should be avoided. The process of decalcification, especially when there is a bony tissue, becomes a deterrent factor for DNA extraction. So coming to the conclusion, the take-home message in this is that NGS is the method of choice to identify BRCA1, BRCA2, and HRR gene point mutations. MLPA is the method of choice to detect large deletions and duplications in the BRCA genes. Somatic BRCA or HRR testing will pick up both germline and somatic variants, thus increasing the number of patients who can benefit from targeted PARP inhibitor therapy. FFPE block preparation is a very crucial step for the successful NGS assay. With this, I thank you all for this opportunity, and we shall be very happy to take up any questions. So there is a question, Dr. Indranil, I hope you're also there. If there are any clinical questions, I will pass it on to you, sir. So there is a question from Mansi. In your study, sample 5 showed 74% allelic ratio. However, blood showed no mutation. How commonly do you encounter this scenario where allele ratio high, no germline mutation? A very good question. So that particular sample is something we are taking much into consideration because we are taking it for further testing. The one possible explanation is that it has a loss of heterozygosity, which is an acquired condition where the somatic mutation along with loss of heterozygosity tends to increase the variant allele fraction. So we are in the process of actually estimating the LOH for that particular sample. I hope that answers your question, Dr. Marks.
Sure. Okay. So it was indeed a very interesting discussion, and Dr. Arun and Dr. Indranil, and thanks a lot for that. And if there are no further questions, we'd like to conclude the session. So I would like to thank our speakers, Dr. Indranil, Dr. Arun, and I would like to thank Genome Labs for giving me this opportunity. And thank you everyone for joining.
Thank you.